My name is Urs Fischer and I am Professor for Acute Neurology and Stroke at the University Hospital in Bern, Switzerland. These are my disclosures. Intracerebral hemorrhage is a terrible disease affecting 2 million people in the world each year. So 15 to 20% of all strokes are due to an intracerebral hemorrhage. What happens if a patient is coming into a hospital? In the emergency room, the first thing we normally do is imaging. Only by imaging, we can rule out whether it is an intracerebral hemorrhage or an ischemic stroke. Immediately thereafter, the patients are then transferred to the intensive care unit. Unfortunately, we often see a clinical deterioration of these patients in the intensive care unit. First, because we do have an enlargement of the hematoma with an intraventricular hemorrhage, but also because we do have a cascade of an inflammation leading to a perihemorrhagic edema, which has a major impact on outcome. So from a pathophysiological point of view, we have an initial phase with a mass effect of the hematoma, which leads to a mechanical disruption and a tissue shift, followed by a secondary hematoma expansion, compression and herniation, and then we do have the phase of the perihemorrhagic edema, which leads to a mass effect, herniation and disruption. So let us discuss the pathophysiology again in detail. So we do have the primary brain damage, which leads to immediate damage by disruption, compression, and herniation, followed by the secondary brain damage with an inflammation, edema, hematomolysis, and cell injury. Then often these patients do have complications such as seizures, hydrocephalus, ICU-related infections, and if they survive this initial phase, we then see the resorption of the hematoma with a clinical improvement. As already mentioned before, we are scared of the enlargement of the hematoma because this not only leads to compression and intraventricular ICH and herniation, but also we know that the bigger the volume of the hematoma, the bigger also the perihemorrhagic edema, which then has a major impact on the outcome of this patient. So what are the potential therapeutic approaches in these patients? First of all, we have to try to avoid the expansion of the hematoma by lowering the blood pressure, hemostatic drugs, and anticoagulation reversal. Other interventions might target on anti-inflammation. So we have steroids or other drugs which eventually have an impact on the development of the perihemorrhagic edema. And last but not least, we have supportive therapies in order to control seizures, control of infections, ICU management, and neurorehabilitation. And then in a later phase, we have secondary prevention measures such as blood pressure control, and we have to discuss when we can start antiplatelets and anticoagulants in these patients. Another option is also to minimize the secondary brain damage by decompressive surgery, a topic which I'm going to discuss later. However, is it also possible to reduce the volume of the hematoma? As already mentioned before, the size of the hematoma volume per se has an impact on outcome, but also has an impact on the size of the perihemorrhagic edema. So if we can reduce the size of the clot by big surgery or minimal invasive surgery, we also have eventually an impact on the perihemorrhagic edema. As you can see here on this busy slide, there have been a lot of interventions tested by randomized controlled trials or prospective studies, such as hematoma removal, blood pressure management, hemostasis, immunomodulation, and so on. Unfortunately, all these have been negative, and no intervention in the management of ICH has been proven to be effective in order to improve the outcome of these patients. If we have failed, we eventually haven't understood the pathophysiology of the condition enough. Therefore, I would like again to discuss the pathophysiology of the perihemorrhagic edema evolution in detail. So we do have an initial phase with neural and glial mechanical disruption, oligemia and ischemia, which then leads to a mechanical stretch, glutamate release, mitochondrial failure, and the cytotoxic edema. So that's the very early phase, followed then by the second phase with a release of thrombin, halotransferin, and then we have the phase of the lysis of the erythrocytes with the release of iron and hemin, followed by the whole inflammatory cascade with microglial activation and the release of all these factors. So we have an initial phase where we do have blood in the brain, we have a breakdown of these products, and the breakdown of these products triggers the inflammation. As you can see here on this slide, the dynamics of the perihemorrhagic edema evolution is different from ischemic stroke. In ischemic stroke, the peak is normally after 3 days, whereas in ICH, the peak is in between 7 to 10 days. So we do have a window of opportunity to treat these patients. We have the early edema growth, and we have the peak perihemorrhagic edema, which play a role. So what is the impact of the perihemorrhagic edema? Multiple studies have shown that the perihemorrhagic edema is an independent outcome predictor in ICH patients. So the bigger the perihematomal edema, the poorer the outcome at 90 days in terms of death and dependency. This is an interesting study by the group of Bastian Folbers in Erlangen. They were looking at the impact of the volume of the clot and the perihemorrhagic edema on outcome. As you can see here, the lower the volume of the clot, the better the outcome. The higher the clot or the bigger the clot, the poorer the outcome. And the same correlation could also be observed in terms of the volume of the perihemorrhagic edema. The bigger the volume, the poorer the outcome. The smaller the volume of the perihemorrhagic edema, the better the outcome. So the difference in perihemorrhagic edema in terms of outcome is relevant. Here you see the variables which are associated with outcome in intracerebral hemorrhage. We have the usual suspects such as stroke severity, age, hematoma volume, and the fact whether we do have an intraventricular hemorrhage or not. And furthermore, we also have the peak perihemorrhagic edema volume, which has an impact on outcome independent on the other factors. So what is more important? Is it the early growth or is it the peak perihemorrhagic edema? And this question also has been addressed by the group of Bastian Folbers. And as you can see here, the most important thing is the peak perihemorrhagic edema volume, and the initial increase up to 3 days is not as predictive as the peak perihemorrhagic edema. Other factors which are important are hematoma volume and ICH score. So is the perihemorrhagic edema and outcome dependent on the ICH volume? Yes, there seems to be an interaction in between the volume and the perihemorrhagic edema and outcome. The group of Erlangen has shown that the perihemorrhagic edema mainly plays a role in patients with smaller hemorrhages. These can be hemorrhages which are deep or lower or overall, but it is more pronounced in patients with a ICH volume of less than 30 ml. So what are potential targets in the therapy of patients with perihemorrhagic edema? If we want to talk about potential targets, we have to look at the different phases of the development of the perihemorrhagic edema because the targets may differ on the phase. In the very early phase, which means minutes to hours after the symptom onset, we have a mechanical cell damage, mass effect, clot retraction, osmotic edema, and cytotoxic edema. In this phase, osmotherapy with mannitol or glycerol or albumin might be potential mechanisms. However, the problem is that this phase is very early, and when the patient comes in the hospital, this phase has already established, and therefore interventions are often too late. The most interesting phase is probably the time window in between 4 to 72 hours, where we have a contact activation, a coagulation cascade, kinin system release, complement system release, the activation of the microglia, infiltration of leukocytes, and then the release of all the cytokines, which then leads to a vasogenic cytotoxic edema. There are different targets in this phase. We can target the coagulation cascade. We can target the microglia activation. We can target the leukocyte infiltration. We can target the pro-inflammatory cytokine release. And we can try to limit the cellular damage by anti-radical and anti-apoptotic drugs. In a later phase, we have the lysis of the erythrocytes with a liberation of the hemoglobin, heme, and iron, with the NO depletion, oxidative stress, and again, vasogenic edema and cytotoxic edema. Also, in this phase, we have different treatment targets, as you can see here. So therapeutic approaches should be phase targeted, they should be proximal within a cascade, and there should be phase specific readouts in order to test whether such an intervention is successful or not. What has been tested so far? As you can see here on this slide, there have been a lot of approaches, but a lot of these studies did not have a clinical endpoint, but only a surrogate endpoint. An interesting drug is deferoxamine, which has been tested in smaller studies, and these smaller studies have shown that patients treated with deferoxamine had a lower increase in relative edema volume compared to controls. Therefore, randomized controlled trial, a phase 2 trial, has addressed whether deferoxamine in patients with intracellular hemorrhage is beneficial. 145 patients received deferoxamine, 149 patients received placebo. Deferoxamine was given in a dose of 32 milligrams per kilo per day, and the patient received this drug during 3 consecutive days and were compared to patients on placebo, and the start of the intervention was within 24 hours. Unfortunately, there was no effect on edema. And there was unfortunately also no effect on outcome. So overall, deferoxamine was safe. However, there was no major impact on outcome, so that a phase 3 trial would not be likely to change clinical outcome. What about fingolimod? Fingolimod is very well known in patients with multiple sclerosis. This small trial has assessed fingolimod in 23 patients with a supratentorial intracerebral hemorrhage. 11 patients received fingolimod for 3 consecutive days within 72 hours, compared to 12 patients receiving conventional treatment. As you can see here, fingolimod had no impact on the volume of the hemorrhage. However, it had an impact on the perihemorrhagic edema and the relative perihemorrhagic edema. Another interesting drug is siponimod, which has been tested in animals. Siponimod in different doses had an impact on the outcome in these animals. As you can see here, multiple low dosage was associated with a reduced perihemorrhagic edema evolution and clinical improvement. However, the mechanism is unclear, especially it's unclear why the high dosage was not effective. So siponimod could be an interesting drug which should be tested in patients with intracerebral hemorrhage. Other interventions which are of interest are mannitol, statins, hypertonic saline, and blood pressure lowering. And last but not least, hypothermia has been discussed in patients with intracerebral hemorrhage as well as ischemic stroke. What about surgery? Is surgery effective in patients with intracerebral hemorrhage? We know from randomized controlled trials that removal of the clot in patients with intracerebral hemorrhage is not beneficial. The question is whether minimal invasive surgery improves the outcome in these patients. The MISTI trial was a randomized controlled open label blinded endpoint phase 3 trial which tested whether minimal invasive surgery in patients with intracerebral hemorrhage is beneficial. As you can see here, patients with an intracerebral hemorrhage received stereotactic removal of the clot by injecting of alteplase. And as you can see here, they were able to remove the clot in these patients. Unfortunately, MISTI did not show any clinical difference in patients treated with standard medical care and the intervention. However, MISTI has shown that patients who had reached a treatment target of less than 15 milliliters had a better outcome compared to the overall cohort. So what can we learn from the MISTI 3 trial? It is an excellent study which was unfortunately neutral, and 1 year after the ICH, 80% of the patients were living at home. The prognosis for large ICH might not be as poor as suggested, and exploratory secondary results suggest that clot size reduction to less than 15 mil was associated with better modified ranking scale scores. Further trials on minimal invasive surgery for ICH are ongoing. So what about decompressive surgery? Decompressive craniectomy is highly effective in patients with malignant MCA infarction by reducing the perihemorrhagic edema. So the mortality and handicap are dramatically reduced. We know that the perihemorrhagic edema develops later in patients with intracerebral hemorrhage. So therefore the question arises whether decompressive surgery could be beneficial in these patients. As you can see here, the concept of decompressive surgery in patients with intracerebral hemorrhage has not been tested. Therefore, the SWITCH trial is an international trial investigating whether decompressive surgery in combination with best medical treatment is superior to best medical treatment alone. SWITCH is an international trial which is led by neurologists and neurosurgeons. The primary objective is to assess whether a strategy of decompressive surgery and best medical therapy in patients with spontaneous ICH will improve the outcome compared to best medical therapy alone. Patients coming to the emergency room fulfilling the inclusion-exclusion criteria can be randomized into the switch trial. Patients who do not want to be randomized can be followed up in the observational arm. Main inclusion criteria are spontaneous intracerebral hemorrhage, patient must be older than 18 years and younger than 75 years, the Glasgow Coma Scale must be in between 7 and 14, NIH in between 10 and 30, and the ICH volume bigger than 30 and lower than 100 ml. As you can see here, it's important and relevant that only patients with severe ICH are included in this trial. Furthermore, the patients have to be shown that they have a stable clot volume. Currently, 132 patients have been randomized into SWITCH, and SWITCH have become the biggest trial on decompressive surgery in patients with stroke. 36 sites are currently contributing to the trial in 9 countries. And as you can see here, we still have a male predominance in this trial. 2 patients have been lost for follow-up, 38 patients died, but the patients at inclusion were younger than 60 years on average. They had a Glasgow Coma Scale of 10, an NIH score of 18, and a volume of 54 ml. There are other ongoing trials in patients with intracerebral hemorrhage. There are trials facing the hematoma enlargement, trials looking on the secondary brain damage, there are surgical trials and post-ICH medication trials. Here and in the next slide, you see an overview on the ongoing relevant trials targeting the perihematomal edema. Let me conclude. Perihemorrhagic edema has a relevant impact on outcome in patients with intracerebral hemorrhage. The impact is probably higher in patients with smaller ICH. Current studies have failed to decrease the perihemorrhagic edema and thus outcome in phase 3 trials. Promising drugs are currently tested. Minimal invasive surgery did not improve the outcome of ICH patients, and decompressive surgery is eventually an option for patients with large ICH, which means bigger than 30 ml. I would like to thank my team, especially Bastian Folbers, Kevin Ackeret, and many more for contributing to this presentation. Thank you very much for your attention.